Good afternoon. Welcome to the Sarcoma Foundation of America's panel discussion, Sarcoma and Coronavirus. My name is Lori Hoffman. I'm the Director of Advocate Engagement and Public Policy at the SFA, and we look forward to a dynamic discussion today. Before we begin, I'd like to briefly go over the format and logistical details for the webinar. We have 3 panelists and a moderator today. The moderator will ask the panelists questions that were submitted prior to today's discussion. If time permits, the moderator will also include additional questions submitted through the question component of the webinar. This webinar is intended for educational and informational purposes only, and it is not a substitute for medical advice from your physician about your particular situation. Today's discussion is being recorded. The discussion will be archived, and a link will be provided on SFA's website. And all participants are muted, and any questions or comments can be submitted through the webinar's question portal. So now I'd like to introduce our panel members for today. Joining us is Dr. Brian Van Tine. He is an associate professor of medicine in the Department of Medicine at Washington University in St. Louis, Missouri, where he is the sarcoma program director at the Alvin J. Siteman Cancer Center. He pursued his postdoctoral fellowship studying mouse genetics and genomics and tumor xenografting while clinically specializing in the treatment of sarcoma. His laboratory is dedicated to understanding the metabolism of sarcoma. Also joining us today, Dr. Kurt Weiss, who is an associate professor in the University of Pittsburgh Department of Orthopedic Surgery, Division of Musculoskeletal Oncology. He is the vice chair for translational research and director of the Musculoskeletal Oncology Laboratory. He established and developed a translational sarcoma research program at the University of Pittsburgh that continues to grow and thrive. His research focus is understanding osteosarcoma metastatic potential and developing novel therapeutics to disrupt the metastatic process. He is also interested in the metastatic programs of other sarcomas and sarcoma-associated cachexia. Also joining us today is Dr. Breland Wilkie. Dr. Wilkie is Associate Professor in Medical Oncology at the University of Colorado School of Medicine. She is involved in patient care, clinical trials, and laboratory research, particularly focused on immune therapies for sarcoma. So again, thank you to all of our panelists for joining us today. And now I'd like to introduce SFA's Executive Director, Brandy Felser, who will moderate the discussion this afternoon. Brandy?
Thank you all so much for joining us today. We are so excited to say that we had over 200 people register for the program today, and we received many questions. And while you may not hear your particular question, we did our best to divide the questions that were submitted into themes. If you have questions to submit through the question portal during the discussion, please be sure to make them specific to sarcoma and COVID-19. The panelists are unable to answer any questions about your specific treatment. So as Lori said, we look forward to a dynamic discussion. So let's get started. First question, Dr. Van Tine. In general, and in relation to COVID-19, what do sarcoma patients need to know about their risks? And can you touch upon whether the risks are higher for someone who is actively receiving treatment as opposed to someone who may be in remission or whose treatment may have ended some time ago?
No, thank you so much, Brandy. I would like to thank the foundation also for going out of their way to make this event happen. I think that communicating to people who are feeling isolated at this time is important. And I think that, you know, the group of us that came together are in agreement with most of the rest of our colleagues that, you know, we're working together as a very large team. You know, if you look at sarcoma patients across the spectrum, I think there are those that just had surgery, those that had surgery and radiation, and then those that have had chemo. And I think as we get into risk stratifying, you've got patients that actively have to maintain their therapy for survival, and then those that have been treated. I think patients that are under active treatment have to have very careful discussions with their oncologist, but most of them will need to remain on therapy, but they're of highest risk if they get something like COVID-19. I think where it gets more complicated is in the patients that have had chemotherapy, and how many years out do you have to be from chemotherapy before you're at lower risk? I know that I generally tell most of my patients you have to be at least a year out for chemotherapy before you start to feel normal, but in terms of your immune system, it may be many, many years. And so I think that patients who have had chemotherapy, and I think Dr. Wilkie can chime in, should probably consider themselves of high risk whether or not they are of high risk. And from that standpoint, stay at home, wash your hands, and make sure that you're social isolating to the best of your ability.
Yeah, just to chip in there. Hello, everyone. Again, I'm thrilled to be here. But basically what I've been telling my patients is that, we're all in this together. There's all a tremendous amount about this virus and what it means for all of us that we really don't know yet. And it puts us in a tough position to offer counseling to our patients who are understandably really concerned. I mean, this is a balancing act. Whenever we talk with you about your sarcoma and what your treatment options are, it's a risk and benefit ratio. And what makes this so hard right now is that coronavirus is on that risk side of things, and it may alter that risk to benefit ratio when you're making decisions. But I agree with Brian, I'm sorry, Dr. Van Tine, that really, as best we can tell, if your immune system is intact, and by intact, I mean your numbers have returned to normal, you at least have all of the different types of immune cells in your bloodstream that are supposed to be there and they're functioning. We don't have good data yet to say who really is going to be at the most risk. And so we encourage everybody, not just whether you're a cancer patient, but all of us should believe that we are at high risk and that we could potentially be carrying this virus, and to follow those CDC guidelines accordingly, social distancing, hand washing, and so on.
So Dr. Wilkie, to add on to that question, what are recommendations for sarcoma patients if they begin to show symptoms or symptoms even unrelated to COVID-19 outside of clinic hours, such as over the weekend?
Right. So I think the biggest message that I want to get across, and I think I speak for all of us just from our conversations even before this, is that you need to have a very good conversation with your treatment team. And that includes your doctors, your nurses, your on-call logistics, because I can guarantee you every single hospital and every single clinic is obsessing about this right now. How are they going to take care of their patients? How are they going to make sure that the communication is intact? And are there going to be different avenues for patients that think they might potentially have symptoms concerning for the coronavirus? But we can't speak to the nuance of every specific clinic and how they're doing things. But I can tell you there's probably a plan just from all the conversations we've had. So most likely that's going to entail, getting through to your on-call team, being open and communicating about any symptoms you're having. But what I think the best way to think of this is all those communications and the ability to care for our patients is intact, but it may be a little bit less efficient than what you're used to, meaning, most of the doctors and the departments are running on lower levels of people. And that's partially to try to help our healthcare providers and our support staff maintain social distancing, being able to work from home when it's possible. But, we are still here to take care of you, and we want you to get the care that you need and get those questions answered. But the most important thing is to talk with your specific treatment team and know what the protocol is for your site.
If I can just chime in, I had a patient that called in over the weekend, but we had already pre-discussed what to do. So it's very important to have this conversation specifically before 5 on Friday. You should know what the plan is. I mean, you should be talking to your active group of treatment nurses and doctors before you actually need them, so you'll know what the plan is. And, this is a moving target. So the plan this Friday would have been very dramatically different than the plan last Friday. So I think this communication, especially for patients undergoing needed active treatment, needs to be ongoing, and we all need to be safe and very careful.
Great. Dr. Weiss.
Yeah.
How do sarcoma patients manage or kind of determine post-op care issues and deciding whether to have surgery now? And are there any thoughts on how a sarcoma patient determines whether or not to continue a surgery at this time?
Okay, so thank you for having me. And I think what you're probably getting at is what makes something elective versus not elective, right? So let me tell you how a surgeon thinks about something being elective versus not elective. It has everything to do with the reason that you're going to have the operation, what the purpose of the operation is. If it is a threat to your life or your limb, it is not elective. Okay, let me give you a couple examples from my life as an orthopedic surgeon. So hip arthritis. Let's say you've had hip arthritis for 10 years and it's just gotten worse and worse and worse. And now you're having discomfort every day and it's really impacting your ability to do the things that you love. Well, that's a rotten problem. But arthritis never killed anybody. Sarcoma has done that. And so another example from my life, surgery that I'm doing tomorrow on a patient with a sarcoma in the thigh. That is a threat to both life and limb. That can't wait. Okay, so a lot of the operations that my colleagues do, things like knee arthroscopies and joint replacements and things like that, those are not immediate threats to life or limb or both. Most things in the sarcoma universe are risks to life and limb or both. So those things got to happen. That tumor on my patient tomorrow, that's got to come out. Now, that's a broad brushstroke answer. And just to piggyback off of what Dr. Wilkie just said, nobody knows your situation better than you and your team. If there's a specific reason that you've discussed with your doctors and your surgeons and your team of why it's okay for your surgery to wait, then fantastic. But I think also what Dr. Wilkie said was it's important to have those conversations, right? So most of the time, sarcoma surgical treatments do not fall under the umbrella of elective things that can wait for weeks or months until we sort this whole COVID-19 thing out. Most of them got to happen, virus or no virus. But there may be a specific reason why your surgical treatment can wait. And you need to discuss that with your team. Is that what you're looking for, Brandy?
Absolutely, thank you. Dr. Van Tine, we received a lot of questions about obstacles and barriers to treatment and how to proceed with treatment in general, but how should sarcoma patients proceed with treatment and any current treatment change, and what are the risks and benefits to continuing surveillance at this time? And specifically, we got a lot of questions about, should I go get my scans, or I have to drive very far away from home? You know, is it safe to do that?
Well, that's a complex question, but let me see if I can dissect it. I mean, I think that this is the hard part, right? You know, playing off of what Kurt was just talking about, you know, we're starting treatment for an osteosarcoma patient on Monday. This can't wait. They may grow rapidly, they may change. We may take somebody who was not metastatic, and if we wait a couple of months, this may change their entire life's outcome. We have to keep moving forward. And, you know, the risks of doing operations versus the risk of doing chemotherapy or radiation therapy. Sometimes in the right patient, we're changing the order to kind of bridge the danger zone of the next couple of months. But, you know, these are very specific, team-specific questions you should be discussing with your team. But then you get into some very interesting issues. You know, we're putting off most 3-month scans right now for a couple of months in asymptomatic patients. So we're calling them if they don't have signs and symptoms that they don't feel like there's something to worry about, they're not having any symptoms, you know, we're either arranging for scans locally, or we're getting them and not seeing them, or we're just putting them off depending on the type of tumor and their risk. And so that's one thing. You know, we got one very interesting question, you know, should I drive 750 miles to get a scan? And the problem is probably no. You can probably get that locally. There's no reason to drive across multiple states where the risks are higher and lower. You know, I wouldn't be driving to New York City right now for probably any reason, but that's just a personal preference, but it's dangerous, right? Whereas it might be dangerous also to drive to St. Louis in a month. And so you shouldn't probably leave your local regional area unless you have a good reason. But there are, I believe, CT scanners everywhere, MRIs everywhere. People can get local treatment and still communicate with their distant team. And so I think if we kind of think of this from a big, broader perspective, we can still do surveillance, but maybe not necessarily have you drive to where you're used to getting your scans, but we can try to arrange for them locally. Your healthcare needs to continue, but not necessarily the way you're used to it.
Right, and just to piggyback off of that as well, so we have in Denver, I mean, our patients come from really a huge geographical area. I mean, we get people from every corner of the state and sometimes from outside the state. And so one thing that many centers have adopted that I've found incredibly helpful is this telehealth. So this is the ability to have medical grade FaceTime with your doctor. And we've been rolling this out in the last couple of weeks, and I have patients that have had their surveillance scans done locally, and we're able to do just like a regular visit. So talk to you about your symptoms. I've actually been able to show people their scan and to go through it just like I normally would in a visit. And it helps us stay connected, and it helps patients feel like they're not forgotten or that they're not prioritized, and all of these scary things. I mean, we're here and we live in a really amazing time where we actually have these tools at our disposal. I mean, we can get food delivered now. We can touch base with our families and our friends and even our physicians now over the internet. I mean, imagine if this was 10 or 15 years ago. I mean, I think this whole situation right now would be very different.
I think one of the other things we need to probably talk about, and it's probably short-circuiting probably the next question, but I think there is an issue around clinical trials. And clinical trials, especially if you're on one you're benefiting from, get really complicated really quickly. So, I have people who come from, 500 miles weekly here for certain drugs because they can only get them here. This is something where if you're on something and it's working and it's novel, you can't get this at home. This is a conversation where you try to figure out how to best do it safely. But, there are some national clinical trials where sometimes people go to larger centers. They're used to their larger center, but they may be open more closer to your house. And so maybe traveling just to a local site. This is being allowed now. The NCI has done an amazing leadership stand on helping us navigate very difficult times. And so, you may be able to get your clinical trial drug closer to home if that trial is available. And so I think this is one of those conversations that needs to start happening with, my patients who travel a great distance that, maybe there might be something that's closer. I don't know this, I don't have a specific patient in mind, but I think it's also important that we start thinking a little bit out of the box and more towards safety.
Yeah. And from a Dr. Van Tine, from a surgical standpoint, I would say that we're probably doing the same as you and Dr. Wilkie. For example, if it's somebody, I operated on you 4 years ago and gave you a megaprosthesis for your osteosarcoma, and you're doing fine. It's just that you always come to see me at the beginning of April, and it's the beginning of April now. Well, you don't come to the office now. You get a phone call. And I can look at your scans remotely, just the way you and Dr. Wilkie are doing. And so it's really, same thing with you guys. We look after, in Pittsburgh, we look after a pretty broad geographical area, and people come from all over. So we really have to be thoughtful about, geez, who can get by with a FaceTime conversation or a phone call versus who do I really got to bring in. And that is, I said before, and it's true, that my operating room list hasn't changed tremendously, but the office has. And it's given us the opportunity to really sort of discern who got to come in and see me and who we can look after over the phone or with telemedicine.
And just one more point about clinical trials before we move forward. So I just want to clarify that as far as I know, and I think in most centers, this is not a situation where the trials themselves are being canceled. So if you're on a clinical trial and you're getting treatment, with very rare exception, people are not getting pulled off or saying you can't be on a clinical trial anymore. Where we're having the roadblocks is putting new patients onto trials in like new accruals. That's where a lot of times people have been waiting for a spot on a clinical trial, and that's where it's frustrating. But the good news is that most of the time there's something we can do to bridge, because the nature of a clinical trial is that it's an exploratory treatment. So what you will find often is your doctors may be recommending a more standard therapy or something to kind of bridge the gap, knowing that this isn't going to last forever, and that at some point we will be able to get our folks moving onto these clinical trials quickly.
You know, and I also think a lot of the trials have been working very hard. A lot of the oral trials, we've just been mailing drugs, you know,
Yeah.
making sure people are doing okay. We're able to start, at least for now in St. Louis, we're able to start most people on most of the trials I have. I only have a couple that shut down for either logistic reasons and they weren't shut down by me, they were shut down by the company. But these were, you know, vaccine trials. These were things where, you know, you were doing a lot of things to put a patient at even greater risk. And so what's really nice is not only are the companies not worried about their product, they're worried about the patient. And so I think there's a lot of communication going on, and everybody's doing their best to make sure that, you know, sarcoma doesn't wait for COVID, but we can't put sarcoma patients at risk because of COVID.
Right.
Yeah.
So since we're talking a little bit about clinical trials, I'd like to ask the panel, starting with kind of Dr. Weiss, how is the pandemic affecting sarcoma research?
It's a good question. I will say that oftentimes when you're in the laboratory, it's, you know, go, do the experiments, generate the data. That has been at the University of Pittsburgh diminished to a great extent, that experiments and lines of research on the bench that are around clinical trials are absolutely continuing, but we're not starting any brand new projects. That is not an entirely bad thing. The research is still going forward. We're able to take a breath and analyze our data and start writing up our data so we can do a better job of communicating and getting our discoveries out. So I'm not saying that this is a net positive thing, but there are some good things that we can find out of it. The research has not stopped. Sarcoma didn't stop happening, and so Dr. Wilkie and Dr. Van Tine and I aren't shutting our labs down. We're still got our foot on the gas, but perhaps the emphasis has shifted a little bit from starting new projects to tying up old ones and figuring out how to communicate our results a little bit better. Drs. Van Tine and Wilkie, what are your thoughts?
Well, I know that most of my lab has gone to a writing mode. We're still doing a lot of experiments to prove whether or not we should put things into clinical trial. I do find it interesting that a lot of the clinical trials that we were writing, that we were slowly moving along, are now moving along a lot faster. We're in this window where we can actually get things that are going to be up and going right when this is over, moving forward. I'm finding that because everybody's at home now, we can actually get a lot more done. I find the communication's been better. You know, my students are all over the data they have. They're putting their best foot forward. You know, funding that we've had from SFA is actually finally getting that data analyzed so we can get it out. I mean, all of this is happening, and it's just kind of been a shift in how we practice. And so I think that there is still a lot of change coming for our field, and I think we're actually doing a different job, but I think it's being done well.
Yeah, not much to add. I mean, I'm fairly new here in Denver, and so as a new lab trying to get up and rolling, it has been a challenge. And, you know, certainly everybody's priority is safety, and we certainly don't want to drag our postdocs and our grad students and, you know, our technicians into the lab where, you know, everybody's running around, and it's a difficult environment to control. But like you guys, I mean, we've focused on what we have been able to get data-wise, and we're churning away and planning. Really, it's planning the experiments that are next to come based on this, so that as soon as we do lift some of the social distancing requirements and hopefully things get back to somewhat more normal, that we can rapidly jump on things and pick up where we left off.
Right. Dr. Wilkie, I'm going to actually attach a question we got through the chat or the question portal here, but can you talk about the effect current immunotherapy might have on the coronavirus course of treatment, and specifically a question we received, when you refer to chemotherapy, does that include the use of immunotherapy drugs as well?
Great question. So there are a lot of really, really smart people who think about nothing but the immune system all day, that are looking at how this virus acts, how it stimulates the immune system, and how the immune system can be helped to further its attack to get rid of the virus. But cancer sort of plays an interesting role here, and our use of immune therapies, which are designed to increase the immune response against cancer by dropping away some of the limiting, the suppressive factors. It's an interesting question. If you take someone with a immune system that's been supercharged and then they become exposed to a virus, which is already a very potent stimulus for the immune system, what is that going to look like? So there's not a lot of data yet for patients on immune therapy for cancer that have had coronavirus. What we do know, though, is that the people that are getting sickest with coronavirus, the reason that's happening is because their immune system is so incredibly activated by this virus that there's a lot of inflammation. So we're really interested in looking at that, particularly here and other centers where some of the treatment for people that go through coronavirus involves the use of medicines to control the immune system. And that includes medicines like hydroxychloroquine, which can help suppress the immune system, as well as a medicine called tocilizumab, which is designed to blunt some of that super intense cytokine storm, is what they call it. So I think it's something that is certainly on my mind, because a lot of my clinical trials right now are using immunotherapy, and we don't really know. But I think hopefully, or hopefully not, as the cases continue to come in, we have lung cancer patients who also use immune therapy, melanoma patients, and I think we'll have some more answers to that sooner rather than later. I don't know if you guys want to jump in at all.
No, all I can say is we don't know what we don't know, and this makes us very, very hard.
Hi,
It's interesting, though,
Dr.
because
Weiss.
sorry, go ahead.
Oh, no,
Well,
go ahead, please finish.
So again, and this is all hand waving, but I'll just point to a couple of trials actually that have used viruses to stimulate the response against sarcoma. So Dr. D'Angelo and colleagues out of Memorial Sloan Kettering published a study for sarcoma patients using the immune booster pembrolizumab along with a virus, a melanoma virus called TVEC. And the idea of that is that the virus can help stimulate the immune system to turn on. So again, I'm not saying that our patients with sarcoma who might get coronavirus could potentially benefit from that just because of the intense immune response. But if I'm looking for the positive here, I don't think we can say definitively that's not a possibility.
Yeah.
Okay. Dr. Weiss, we had a few questions in regard to lung surgery. So how does the risk and infection of COVID-19 affect patients with a history of lung surgeries for metastasis?
Well, that's a question that's very near and dear to my heart, because as you know, Brandy, I'm not just a sarcoma surgeon and a sarcoma scientist, I'm a sarcoma survivor. And I, in fact, had metastatic osteosarcoma and have been to the operating room myself a number of times to have bits of my lungs removed. So that was a question that definitely hit very close to home for me. So what gives me hope with that question is that there seems to be a tremendous amount of redundancy built into the human pulmonary system. Dr. Van Tine, Dr. Wilkie, and I have all seen people that come into our clinics with CT scans of their lungs that are absolutely terrible, that look awful, and you think, oh my goodness, how's this guy, how's this lady even breathing? And they're walking around like they don't have a care in the world. So from a standpoint of somebody who's seen a lot of lung pathology in people that are walking around like they don't have care in the world, that gives me a lot of hope. So I would say, and again, talk about a lot of hand waving. This is a tremendous amount of hand waving. If you haven't had an entire half of your lung removed or an entire lung removed, I don't know that your response to a COVID infection is going to be that tremendously different than it would be if you had a normal volume of lung tissue, just because the way we are engineered is that there is tremendous capacity to the lung system. I think the folks that are having the most trouble are not people like me who have had bits and pieces of lung removed. They're people that have their entire lungs affected by a problem. So patients that might have a systemic lung issue like COPD or emphysema, I think they're probably going to struggle a little bit, and I think they should be very careful. But I think it's a little bit different story for somebody who's had a bit of lung removed. That's my take as a surgeon. What do you doctors think?
Yeah, I agree. Sorry, I agree. I think that, having surgeries previously, particularly if you don't feel any residual effects from it, or we don't see changes in the oxygen levels in your lungs as a result, I don't think that in and of itself is going to be a problem for recovering from the virus, personally.
No, I'm in agreement. I think we're much more worried about people who smoke.
Yeah, absolutely.
Dr. Van Tine, we had a few questions in relation to caregivers. And what do caregivers need to know, and what can they do to prepare and support their loved ones during this time? And added to that, can you also talk about how caregivers can get support when they can't see their loved ones in the hospital, or they can't go to treatment with them, and they're kind of being left out a little bit given the situation we're in?
I'm often known to say that sarcoma is a family issue. It's just not the patient, it's the whole family. I mean, without that unit intact, it's very hard for the person who's going through treatment to really do it well, and without the caregivers really doing everything that they do, which is actually probably sometimes the harder job. It's hard. And so, I think these are conversations we need to start having, and families need to start having. Do you have your FaceTime set up now? What happens if your loved one ends up in the hospital? What happens if the caregiver ends up in the hospital? You should have that communication set up. You should have a plan. I mean, right now you can't have visitors in hospitals, which is really, really sad, but you should be able to talk to people. You should be able to communicate. You should have that plan in place. People should have their wishes known. I know that one of the things that we have at least access to here is we've gone to telepsychology, and not only is that available at the Siteman for our patients, but it's also there for the caregivers. And so you have to, not only as a caregiver, be as meticulous as the patients. You have to wash your hands, you have to social distance, you have to not get infected. You have to do your best that if you think you have symptoms to separate. But at the same time, you need to have all these plans in place. And then realize that people need to be there to help support you also, because without the caregivers, this is even harder. And so, have your wishes known, have your plans in place, make sure your communication strategies are actually well thought of ahead of time. You may have to get and order another iPad.
Yeah.
Yeah, just to add to that, I mean, so I had a patient this week that came in that wound up having to come into the hospital, and he's on treatment, and it was doing really, really well, but got a different virus infection, not COVID, but a different type of virus infection. But all of a sudden, he had to come into the ER. It was a 20-minute conversation about what was happening, and his wife dropped him off in that, and then he was sort of on his own. And so the thing I want to emphasize so much of what Dr. Van Tine said, it's really, really important that you have those conversations about your wishes with your family now. So, just what came out of that conversation and that hospitalization is that person realized his priority was to stay out of the hospital at all costs. And so that changes what treatments we recommend, particularly for chemo that requires being in the hospital, or maybe we try to pick a medicine to bridge through this time that has a less likelihood of having something acute happen, because that was the #1 priority after that experience. and he got out and everything was fine. But, you know, these are unpredictable times, and like for any of us, it could happen to any of us. So having things in place, making sure your family and those people close to you know what's important to you, and that you know what's important to you, this is the best time to really have that nailed down.
You know, on top of it, these are the conversations that we all should be having anyways.
Yeah.
I mean, once you get into, if you're seeing us, you should have had these conversations. If you smoke, you should have had these conversations. And this is all independent of cancer. You know, people should know your wishes.
And do you have any, to add it to that, do you have any thoughts about patients who are dealing with a heightened sense of anxiety with the COVID scare layered on top of their already anxiety with what they're going through as a patient, and the isolation that's surrounding their current environment?
Well, I think that isolation is probably the worst part about this. And I think, you know, you should be finding out if your neighbor has access to the ability to communicate over the internet. Maybe you need to give them your Wi-Fi password. You need to make sure people aren't socially isolated. You know, patients shouldn't be socially isolated. People who can help should help everybody make sure they have a way of communicating. You know, if you're having issues with anxiety, if you're having issues with stress, you don't know how to handle this, whether you're the caregiver or the patient, let us know. Not only do we have access to telehealth, there are medications that can help make this a little bit more tolerable so that the anxiety associated with this doesn't become all consuming. And, you know, you have to be honest, you have to be truthful, and you're not special. You're probably normal. Anxiety in this time is normal. And so you just have to let us know that this is actually what's going on and you're having issues coping, and we will help you put together coping strategies.
Yeah, just to add on to that, I mean, I think our cancer patients live with uncertainty and fear and not knowing what each day is going to bring on a daily basis, you know, and so you have all, through having to go through what you've gone through, and this goes for caretakers as well, I mean, you've come up with those coping strategies. You know, you're used to social distancing because we've taught you, especially if you've gone through chemotherapy. I tell my neutropenic patients, I'm like, you guys are made for this. Like, you've already been trained, you've got this down. And there's not that much different from what the rest of the world is now being thrown into than what you guys are already professionals at. That doesn't make it easier, but I would say the same sorts of things that you have used as your go-to coping strategies during the worst times of your cancer treatment, reach out to them as well and teach others that may be going through this for the first time what has been helpful. You know, I think limiting the news and social media is really important because it's very easy to just get completely overwhelmed by things. Staying in touch with what's really important to you from a day-to-day perspective, finding the things that bring you joy, you know, even if unfortunately it's not having 20 or 30 people in your home and having those big gatherings or being out and with a bunch of people. I mean, you know, we can still find joy in the little things, and reaching out to what's really important is probably the best strategy that we all should be doing right now.
No, honesty, truth, and I highly recommend the Lego building competition, because you can't get away from reality is of people building superstructures out of Lego, but don't quit living. And one of the messages here is don't quit living. We're just living differently.
Right. We had a follow-up for Dr. Weiss. We had a follow-up question submitted through the question portal. And what about having whole lung radiation? Does that have a different risk than surgery?
So you always, you want to take it with a grain of salt when somebody's talking about something that they don't do themselves. I do not give whole lung radiation, nor do Dr. Van Tyne or Wilkie. So we know a little bit about it because we know some great radiation oncologists, but we don't do it. Is the risk different for someone who's had total lung radiation? The answer is probably yes. I am equally certain that I don't know what that is, or if there is a timeline that, oh, if you had it 2 years ago, I'm just throwing these numbers out. If you had it 2 years ago, okay, maybe you're in a little bit of a danger zone, but if you had it more than 2 years ago, you're fine. I don't know the answer to that. And I apologize to the person who asked the question for my ignorance, But is there a difference between surgery and radiation in terms of the lung? I think the answer has got to be yes. But perhaps doctors Wilkie or Van Tine can save me a little bit here because I don't know the answer.
I think this is a very important question, and the person who asked it needs to call the radiation doctor on Monday. I would
Absolutely.
But the default answer is I would consider you higher risk only because we've done damage to your lungs. And so conceptually to me, you fall into kind of a COPD class. But, you know, I don't know if you got it 10 years ago, if there's a cumulative damage. And so the answer is we don't know. And this means next time we do something like this, we should have a radiation doctor with us.
Yeah. So just to piggyback, it's an excellent point, Brian. You know, you see four of us, including Brandy, but you know, at our institutions, it's an army. I mean, you patients know, and you caregivers know that you don't just come and see one person. You've got a whole team of people looking after you, the medical oncologists and your surgeons and your radiation oncologists, and people that you don't even meet, like our awesome radiologists and pathologists. It takes a whole army of us to look after one person with sarcoma, which is part of the reason why we chose this line of work, right? Is because we get to be part of a team of which you are the captain of your team. So I endorse what Dr. Van Tine said, 1,000,000%. Call your radiation doctor this week and ask him or her that question, and be the captain of your team. Take some leadership and ownership of it.
Right. And one more quick follow-up question, just to specify another question that came through the portal is, how far out, if someone chooses to delay their scans, how far out can that extension happen before it's considered too long? So is there a time frame that they need to be concerned about?
Yeah, so I'll answer that if that's all right. So basically the guidelines we've made up for how often people need to get scans are not set in stone. And there's actually many people who feel that the data saying that you're more likely to catch a sarcoma on a scan without any symptoms is not probably as strong as we'd all like to think that it is. And this particularly goes for patients getting MRIs of extremities. And Dr. Weiss, you may want to jump in there too. I mean, a lot of the time, if we see something on a scan, we may not even act on it right away. It's more of a, you know, just again, kind of lowering the threshold for how often we need to be following things up. So, you know, again, if you are somebody that is fresh out of treatment and you're thought by your team that you're at high risk for something coming back, or we know there's something there that we're kind of watching, you know, those are people that should probably get scanned, particularly if there's the ability for local interventions and things like that. But if you're a couple years out and you're on the every 6-month plan, the data supporting that every 6 months is very hand waving, and there's a lot of things that go into that. And so again, I wouldn't push, if it were me, I wouldn't push that need to get that scan, potentially going into a clinic, into a hospital, laying on a CT scanner that hopefully they cleaned from the last patient. I mean, it just, overall, it doesn't give you that much.
So Dr. Rilke, I can tell you that we're trying to work through exactly those issues right now in the Musculoskeletal Tumor Society, in trying to come up with cogent reasons of when we get scans and why we get scans, other than, you know, it's been 6 months. But I couldn't agree more with your point. If you are somebody who had a really bad high-grade tumor with a close margin and you just had your surgery 3 months ago, you should probably get your scan, right? If it's been 10 years and you just happen to get your scans in April, it's probably not as good of an indication, right? So we seem to be coming back to the same point all the time, but that's okay. Talk to your team. If you are someone who's at high risk and you need to get a scan in an intelligent way, like Dr. Van Tine said, close to home, in a way that doesn't put you at risk and doesn't bring you to the hospital unnecessarily, go ahead and do it. But before you just go and do it, make sure you communicate with the folks that know you best.
You know, I think of it, you know, a little bit slightly differently where, you know, if you're in your first 2 years, it's a bigger question than if you're past your first 2 years out. You know, 80% of people that are going to relapse in the first 2 years. And, you know, if you miss a 3-month scan and go 6 months somewhere in there, you know, I don't think it's going to dramatically alter most people's course. You know, you catching something like angiosarcoma early may be more important than catching some of the other ones. I think it's on a case by case, disease by disease. You know, who I put off versus who I've moved around really has to do with risk assessment. You know, I have been putting off a lot of, you know, year 4 scans to year 5 at this point, just because, you know, I don't want to lose anybody. And so it's case by case, disease by disease. You know, we collectively treat 175 different diseases, which makes having these webinars hard because this is not a one size fits all group.
Absolutely.
And so, Brian,
Yeah.
you know, maybe some good will come out of this, right? Maybe by delaying some scans in some patients and seeing, you know, looking at them retrospectively, how did we do? Did we miss a lot of things? Did we do okay? Maybe this is going to be an opportunity to answer some important questions.
I think that when we all sit down and look, we'll figure out whether or not where the principle of do no harm actually fits into this later.
Yeah. Well, in terms of delaying scans, there was a question on the portal that asks about interrupting chemo until the COVID situation is more stable. Do any of you want to tackle that one?
That's really a very complicated case by case discussion that I'm having with my patients. Curative chemo, I have a very hard time delaying. You know, treatments for Ewing's, treatments for osteosarcoma, these come with 80% lifetime cures. And what happens if you put off and, you know, create a 3-month middle? Does the virus, you know, does the tumor find a way to escape, evolve? And am I going to hurt somebody? You know, in an older person who's been stable after, you know, 8 cycles of gem tax, is it something where we can put them under surveillance? Probably. I mean, this is a case by case, very careful discussion where it's a risk and a benefit. And, you know, if it's a hard question. It's not a fair question. Nobody should be asking this question. Nobody should have to ask this question, but we are. And so this is that, go back to your team and say, what is the safest for me versus, you know, if we lose control now, is it my last line of therapy and do I want to walk away from it? And you remember, I like what Dr. Weiss said. You're the captain of your own ship. You know, I exist to give information. I don't dictate. It's all about what you want, how you want it, and what you want to do. But, you know, it's an informed decision. So it should be a conversation and not an edict. And so I think this is one of these things where it's hard. And it's hard to sit back and wonder what if.
Yeah,
So
I agree. Go ahead.
we had a question come in actually via email prior to the discussion today, and I'm not sure which one of you might want to take this on, but the question was, genomic testing is a first step toward exploring the use of many immunotherapies. How are the labs that processing this testing being affected by the pandemic? For example, has their expertise been diverted to work related to the pandemic?
No, that's a great question. So again, I think everything is a little bit less efficient right now. And so let's say, so first of all, the genetic testing may or may not influence immunotherapy choices in sarcomas. So I think that the need for genetic testing specifically to say, yes, you should have immunotherapy or not, that's still under a lot of exploration. And I wouldn't say that your decision about whether to do immuno or not should depend on your genetic testing. So that's the first thought. The process to get someone's tumor sent to someplace like Foundation or even our internal genetic testing, our molecular oncology group, has been slower because there are fewer pathologists to go back and pull the sample. There are, you know, fewer people to send out the sample. There are fewer people taking it in on the other end. So it's kind of like, you know, the weekend, but a really massive weekend, and we're sort of even worse than the average weekend is the way I'm explaining it. So yes, things can be pushed through. I can pick up the phone and make a phone call and beg my pathologist, you know, and say, this is why X, Y, and Z, this patient really, really, really needs this done right now. And things are moving forward. But that's where we are, is it's your team needs to be the advocate for you among everybody else, and really have a clear discussion with you as the captain and with all of our infrastructure to say why this person needs this test right now. And so I don't think it's a wall. I don't think that you're not going to get something that you need if it's clear that your treatment depends on that. But I do agree that it's sort of, you know, the world's most painful weekend right now.
I'd like to echo that. First off, I don't tie my immunotherapy decisions in sarcoma to any testing, mainly because we've shown any correlation. And, you know, we've participated in all the trials. I've seen all the correlatives. They're weak. And so you shouldn't make that decision based on sequencing. But I know right now I'm getting my Tempest sequencing right on time. And so I think some of the technology companies are still functioning at a speed that I am still getting information I need back when I'm looking like for translocations, for diagnosis, for round numbers. You know, some of the where I rely on sequencing, you know, for, you know, there's always that one in a you know, a million chance of somebody having a you know, an NTRK fusion, which would change course. But most of the time it's for, you know, confirmation and for looking for a couple of things that might change what I do. You know, just sequencing is actually much more important. And so, you know, figuring out if somebody has a, you know, D842V in GIST would actually change their treatment course. And so we're pushing that all GIST still gets sequenced. And so it just depends on which of the diseases we are really heavily involved with. You know, I don't see a reason to be sequencing a Ewing's patient right now unless I have a really good genetic predisposition question I'm asking.
So one of the questions that we've gotten a lot of, we just got another one through the portal, but I think it's an overall question that goes back to anxiety. And on top of everything that we've heard to do, wear the mask, wash your hands, don't touch your face, all of those things, is there anything else that patients should be doing or precautions they should be taking, or even caregivers, in terms of beyond the standard recommendations that maybe you would recommend for them?
Yeah, I mean, I've had that question at least every clinic visit multiple times. I mean, it just comes up a lot. And again, I kind of go back to what I had mentioned, that, you know, if you've been on chemotherapy, you are trained for this. Like, the masks, I think, it's an interesting question with the masks, and I don't want to get into all of the CNN and political drama that's gone back and forth on the great mask question. My patients, if they're on chemotherapy, if they're neutropenic, should be wearing a mask. And most of our centers, or at least my center, is putting a mask, a regular surgical mask, not an N95, not a bandana, but like a regular mask that you would use if somebody's accessing your port, right? So they put a mask on you so you don't cough or sneeze on your port. I mean, so that makes sense if you're on active chemotherapy. Otherwise, you know, what more should we be doing? I had somebody ask me if there was a better, like, if they should be washing their towels and sheets more often, and I was like, I don't think so. But again, you know, if your sheets are particularly dirty or your towels are particularly dirty, yeah. But you know, so I don't think there's a magic bullet to more of the precautions. But obviously, as we've talked about, it does impact your treatment, and so your day-to-day decisions about, you know, what risks you put yourself at to keep up with your treatment and to fight your cancer. I think that's where you'll see the biggest impact that's different for our cancer patients or sarcoma patients than the average person. Most people are not going to be going to the pharmacy 24/7. Most people are not going to be going to the hospital or to a clinic. And, you know, and I tell people, well, somebody has to go to the pharmacy and get these medicines, you know, otherwise you're going to have a much more likely problem than the chance of you picking up coronavirus at the pharmacy if you're staying 6 feet away from everybody. So I wish I had something more. Maybe you guys, is there a magic bullet you're not telling all the rest of us?
I am not privy to any magic bullets. I think it sounds like at University of Colorado there and University of Pittsburgh are following a similar playbook. I'm supposed to wear a mask around the hospital. I'm fine with that. I'm also not going to get into the data behind that. That's what they've chosen to do, and I think it's reasonable, so I'm going to do it. I hope we've all become a little bit more vigilant. Certainly I have, about doing a good job washing and being careful and being thoughtful, and things that Brian spoke about this earlier, stuff we probably should have been doing all along, right? Like making your wishes known to your family members and so forth. I hope I'm doing a better job now, because this sounds a little bit trite and corny, but I think it's absolutely true. We're really our brother's keeper in this one. Everybody is really affecting everyone else. So I don't think that there are any sarcoma specific special things that our patients ought to be doing. But I hope they're all, I love my patients, and you guys are no different. I really hope that our patients and their families are all practicing these safety guidelines for their own sakes.
I would say a lot of this comes down to practical common sense. Given a choice between going into Walgreens and going through the drive-through, go through the drive-through. If your Walmart will bring it out to your car, that's probably a lot better idea than going shopping for yourself. You have to kind of navigate the options that you have. This curbside pickup, these things are things that you should be actively pursuing, as opposed to somebody being brave. If these aren't options, they're not options. But, I think there are some well thought out strategies, and, Amazon is still delivering. And so it may suck never to leave your house, but it'll suck less when you get to leave your house later.
Right. So we are almost at the end of our time. We don't have much time left. So I'm going to give each one of you, starting with Dr. Wilkie first, but each one of you kind of final thoughts of what should sarcoma patients know? What are your final thoughts for them for this discussion?
Final thoughts. All right, I'm going to do top 3, okay? Number 1, we are still here to take care of you, and you are still important. You are a priority, and we will find a way for your treatment to happen, even with all of these things going on. That's priority number 1. We're still here. Concept number 2, and I'm going to steal other people's because it was just that great, is you are the captain of your own ship, which means that everything that comes to you, everything that revolves around your care, you need to have a central role in making calls for that. And that's how you're going to have your discussions with your team, your discussions with your family, making those critical decisions. It really comes down to you and what is most important to you. So figure that out now and have those conversations. And then number 3, again, take care of each other. As scared and as lonely as you are, there are other people out there that are 10 times more scared and lonely. And so whether that means jumping on those SFA portals or talking to people online, again, within what we can do, the Mr. Rogers quote about look for the helpers. Even right now, stuck in our houses, you can have an impact on other people's lives. And I think finding creative ways to do that and get out of your own bubble and your own anxiety helps tremendously.
Dr. Weiss?
I think the most important thing is what Bree led off with, that we haven't gone anywhere. We are this, we're physicians. We are social creatures. We love seeing patients. We love interacting with you and your families. What we're going through is nothing compared to what you're going through. But the fact is that we don't enjoy this isolation either. For right now, it's a necessary evil, but you need to know exactly what Dr. Wilkie just said. We haven't gone anywhere. We are still here for you, and you need to communicate with us if you have questions. You are not bugging us, so go ahead and call, pick up the phone, get on the computer, do whatever you got to do to communicate with your team. As you have questions, we will work through them with you, as we always have and we always will. My mentor, Pete Ferguson, when he first diagnosis with someone with sarcoma, says, look, you've got a rotten problem, but it's both treatable and curable. And these are the things you need to hang on to. And this relationship that you have with your team didn't just dissolve because of some stupid virus. So use us, use your team, and look after yourselves.
I gotta follow that. I think the symbol of sarcoma is, a yellow ribbon that ties us all together. You're not alone. And, you know, I think that one of the most amazing things I see is, you know, there must be hundreds of Facebook subgroups for each histology. So reach out to each other and just say, you know, I value you. You know, one of my patients said, you're not allowed to get sick. And, you know, it was very kind and very well said. And I said, we're doing our best, but we're still here for you. And so we're going to get through this as a community together. But just make sure that everybody who's in your little chat room knows that they're not alone and that you're there for them also. And it'll help with the social isolation. Maybe beyond just putting comments on Facebook, you can start having Facebook video chats, and then we'll all be better friends. Because, you know, the three of us and the people at SFA are all friends, which is why everybody quits dropping all, you know, our first names. But you know, this is a tight community and we're all here for you. And so, you know, I can't thank the foundation enough for stepping in and so quickly putting this together, because I think it just shows that we're all in this together and will continue to be.
Well, thank you for that. And I just want to say kind of my takeaway was communication. And I think all of three of you just spoke about that as well, as communicating with each other and getting support from each other, communicating with your loved ones during this time, and then also really communicating with your teams and the teams that you are with all the time in your care, communicating with them so that they can help you navigate the situation that we're in right now. But with that, this certainly was a great discussion. And on behalf of SFA, I want to thank Dr. Van Tine, Dr. Weiss, and Dr. Wilkie for joining us and sharing your time and expertise today. And again, we did put this together very quickly, so I appreciate you rallying very quickly to help us with this. And then I want to thank everyone who participated today. I know this is a very uncertain time for all of us, but especially for sarcoma patients, survivors, and caregivers who are trying to navigate this in the best way possible. And I want you to know that SFA continues to be able to provide support to the sarcoma community in the best way we can. And please be sure to continue to follow SFA. We plan to have more of these types of discussions and educational webinars as we go forward. So with that, I will turn it over to Lori.
Thank you, Brandy. And thank all of you for joining. Again, as a reminder, today's discussion was recorded, and we will be making the link available on SFA's website. And you can find SFA online at www.curesarcoma.org. Again, thank you to our panelists. Thank you to everybody else for joining us today. And that's the end of our discussion. Thank you.
Thank you so much.
Everybody take care.
Stay safe and healthy.